Bismillahirrahmanirrahim. This paper was published in 2017 in the International Endodontic Journal by Igor T. Siz et al. And the title is Does Root Canal Treatment in Necrotic Pulp or Retreatment Cases with Preapical Lesions Require Anesthesia in Vivo Clinical Study? It was designed to compare the length of the canal, which was measured using an electronic apex locator, or with the length at which the patient felt the first sensation of an endodontic file touching the preapical tissues. They included all teeth which had negative responses to cold test, a total of 40 canals with necrotic pulps, and another 40 root canals indicated for retreatment. All teeth are asymptomatic before the procedure and with preapical radiolucency. The treatment was performed without anesthesia. In the necrotic teeth, the file was slowly advanced within the root canal to a point at which the scale of the apex locator display read 0.5 mm. In retreatment cases, once the root canal filling was removed, the apex locator was used to determine the electronic length of the canal, 0.5 mm reading at the apex locator scale. For the periodontal length, the file length at which the patient first reported a sensation of the file touching the preapical tissues, this measurement was defined as the periodontal length. The results: no case of pain during the negotiation and measurement of the canal occurred in either the primary treatment group or the retreatment group. None of the cases needed local anesthesia due to pain during instrumentation of the root canal to a working length of electronic length 0.5 mm. Figure 2 showing the distance between the electronic length and the periodontal length as measured in non-anesthetized patients. The difference was calculated by subtracting the electronic length from the periodontal length. The mean difference between the periodontal length and electronic measurements when all the 80 canals were pulled together as one group was 0.7 mm. The difference between the periodontal length and the electronic length measurements in both groups and in the pulled group of all 80 samples were significant. The distance between the working length and the first place that the patient experienced any sensation was almost 1 mm. This distance represented the sum of the difference between periodontal length and the electronic length plus the 0.5 mm as shown in this figure. The clinical implication of these results is that if the clinician is using an electronic apex locator when treating teeth with no vital pulp and with preapical lesions, and if working length is determined and kept 0.5 mm short of the electronic length of the canal, most of the patients will not feel any pain. This study included only asymptomatic cases. Similar symptomatic cases may require anesthesia, and in multi-rooted teeth may have roots with preapical lesions while having other roots with no such lesions. And since in roots with no preapical lesions, remaining vital pulp may sometimes be encountered, local anesthesia or intracanal anesthesia may be required. Local anesthesia for treating necrotic pulp and retreatment cases may be required also and used for a variety of reasons, such as the painless placement of rubber dam clamp or even to satisfy patient expectations. However, the avoidance of pain when working within the root canal should not be counted as one of these reasons in cases with preapical lesions. In conclusion, in root canals of necrotic pulp or retreatment cases associated with preapical lesions, length measurement with an electronic apex locator allowed painless treatment without the use of local anesthesia. There was no difference in this respect between primary root canal treatment and retreatment cases. Thank you.